Okay. Give us countdown, na? Acha, we are live. Okay. Ronak, we can start.
Good evening, everyone. Welcome to the cardio colloquium here today on the Sunday of 29. So, there's a lot to discuss on the topic of hypertension and diabetes, and is there any hope? So, to move further, I would like to invite our eminent moderator, Professor Dr. Kadir Ganguly. Sir is an ex-HOD in the Department of Cardiology. Sir is also a senior consultant cardiologist at Manipal, Apollo, and BM Birla Hospital, Kolkata. Sir definitely doesn't need any introduction. We are really happy to have you here today, sir. Apart from that, we have Dr. Partha Chaudhary. Sir is a chief consultant cardiologist in Jharkhand. We also have Professor Dr. Neerav Kumar. Sir is the HOD of cardiology at Big Apollo Hospital, Patna, and Dr. Abhishek Singh, who's a consultant cardiologist in the Manipal Hospital, Ghaziabad. So we welcome you all here today. And without taking much of your time, requesting Dr. Ganguly to please take over and discuss hypertension and diabetes. Is there any hope? Over to you, sir.
Okay. So good evening, everybody. Thank you, Dr. Ronak, for a beautiful introduction. So we shall move out to discuss the role of AC inhibitors basically in hypertension and diabetes. Also, I shall include chronic coronary syndrome. Right. So may I have the first slide, please? So you can see the distribution of hypertensive patients worldwide. In North American Caribbean island, you see in 2017 it was 46 million. In 2045, it is projected as 62 million. In Europe, again, 2017, 58 million. In 2045, it is 67 million. In Southeast Asia, you see a huge increase. See, 2017 it is 82 million and projected 2045 it is 151 million. Same is in Africa, Middle East, and South and Central America. In India, we had India Heart Study. There we found that it is published in Indian Heart Journal. There we found that almost 30 to 35% of our population in the urban area are hypertensive. In rural area, it is slightly less, 26 to 28%. And alarming is that the incidence of hypertension even in school-going children, it is becoming higher. Next. So diabetes and hypertension is the common risk factors which is due to this insulin resistance in both the groups and associated with dyslipidemia, obesity, and genetic predisposition. It leads to this atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling. All these lead to microvascular disease and also macrovascular disease, which are the common vascular changes in cardiovascular, which leads to cardiovascular diseases. Next. So, the presence of diabetes doubles the risk of a wide range of vascular diseases. It is the 2 times more higher vascular diseases in diabetes. CVD accounts for 50% of all death in people with diabetes. CVD affects 32% of all population with type 2 diabetes. So 50% of the patients with diabetes will have cardiovascular disease in the form of, that is the cardiac events like heart failure, coronary artery disease, or stroke, CBD, or peripheral arterial diseases. Next. Attributable death due to different risk factors. You see, highest is the diabetes mellitus, then comes smoking, and then come high blood glucose. So these are the common three factors which lead ultimately to vascular diseases and death. Next. So in UKPDS, if you see, intense lowering of this diabetes causes decrease in the 14% decrease with 1% reduction in HB1C in fetal and non-fetal MI. Fetal or non-fetal stroke, again 12% decrease, simply 1% decrease reduction in the HB1C level. Amputation or death from PVD, 43% decrease per 1% reduction in HB1C, 16% reduction of heart failure with 1% reduction of hemoglobin A1C. Next. So reduction of CB morbidity and mortality. So if you see the that is the green one, BP from placebo or less intense BP lowering compared with the intense BP lowering associated with CB benefits. In all the studies, HOT, SHAPE, UKPDS, HOPE, I shall come to it, Europa, Progress, and this other IDNT renal and IDNT IM trial all shows benefit with intensive lowering of blood pressure compared to conventional treatment. Next, it is said 2 millimeter lowering of systolic blood pressure reduces the incidence of stroke by 10%, incidence of infarct, myocardial infarction by 5%. Is there any hope? Next. So, AC inhibitors, if you see, we have got number of trials in heart failure, post-MI, heart failure or LV dysfunction with dilated cardiomyopathy, ejection fraction less than 40%. We have got SOLVE trial, SAFE trial, AIRE trial, TRACE trial, and the SMILE trial. In high-risk groups, we have got the Europa trial, Europa less high groups, and in HOPE trial, high-risk patients are taken into consideration. Next. So HOPE study, it was published in 2000. Just to recapitulate, I shall give the outline only. It was a single, large, simple, fractional designed placebo-controlled trial to assess the AC inhibitor ramipril in patients over the age of 55 years of age with evidence of vascular disease or diabetic mellitus plus one risk factor. So it has got, it was published in 2000 only, and we have got HOPE sub-study, we have got HOPE 2 extension study, and ultimately we had HOPE 3 trial also. Next. So HOPE trial design and baseline characteristics. See, with ramipril and placebo. Hypertensive patients, almost same in both the groups. Coronary artery disease almost 80%. Peripheral arterial disease 40 to 45%. Diabetes mellitus 40%. Myocardial infarction around 50%. Current smoker is again 14%. Next. So that showed this reduction in the event after 1 year with ramipril in high-risk patients. It was alarming. It was very, very encouraging. See, relative 22% reduction in the event at 1 year. That is the MI, stroke, and CV death, primary outcome. Next. Microvascular and macrovascular outcome, if you see in people with type 2 diabetes, that is the primary outcome of MI, stroke, or CV events in diabetes, it was 20% reduction. Relative risk reduction. All-cause mortality, 24% reduction. Cardiovascular death, 37% reduction. Stroke, 33% reduction. MI, 22% reduction. Next. These are all known. Just we are recapitulating for our discussion. So risk of CV death, MI, stroke, and development of diabetes. In HOPE trial, CV death, MI, and stroke significantly decreased. If you see, new onset diabetes significantly decreased. HOPE 2 new onset diabetes also there is significant reduction. And in HOPE-2 also, this sub-study in diabetes, TCB death, mortality, MI, stroke in diabetic patients significantly reduced. Next. So, clinical impact, absolute risk reduction was very good, very encouraging, 3.8%. NNT, that is number to treat, is 26%, 26 patients treated for 4.5 years to prevent one CV death, MI, or stroke. Wide range of patients with vascular disease are included. High risk patients, 4% annual event rate. 10 milligram ramipril OD in HOPE trial. It was given to the high risk patients. You can see that the blood pressure reduction starts with 2.5 milligram, but this atherosclerosis reduction or the prevention of atherosclerotic diseases starts at 5 milligram. Next. So higher dose is needed to have vascular remodeling and prevention of atherosclerosis or progression of atherosclerosis. Possible atherosclerotic mechanism of ramipril. Ramipril produces endothelial, corrects the endothelial dysfunction. It causes plaque stabilization, and it also reduces the local mediators, that is cytokines, BCAM, ICAM, and cytokines. And it also reduces PI1, thereby it reduces thrombosis, inflammation, and also it stabilizes the plaque by its bradykinin effect. Vasoconstriction is prevented by bradykinin. We shall come to it. Growth factor reduction, it produces vascular lesions remodeling, and proteolysis prevention. It prevents plaque rupture. Next, this is important for us to prevent this cardiac event. So atherosclerosis reduction in HOPE and SECURE trial. Effect on edema media thickness, that is bicarotid ultrasound. That shows that 10 milligram ramipril reduced the atherosclerosis by almost 37% in carotid edema thickness, if we consider. Next. That is a non-invasive target for seeing the atherosclerosis. Next comes the Europa trial. Europa trial was done on perindropil 4 to 8 milligram daily. So it was done in low-risk population with stable coronary artery disease. So it was again taken patients on hypertension, coronary artery disease, peripheral vascular disease, diabetes mellitus, myocardial infarction, and current smoker. All those parameters are almost matched in both the groups, perindropil versus placebo. Next. So atherosclerosis, as I've said, yes. So relative risk reduction was again 20% with perindropil 4 to 8 milligram daily. Next. That is a CV death, MI, or cardiac arrest. So comparing HOPE and Europa trial, you can see that there is significant reduction, relative risk reduction. If you see myocardial infarction in HOPE, 26%, death from cardiovascular causes is at 26% again, myocardial infarction 20%, and stroke again 32%, as I've said. In Europa trial also, relative risk reduction in cardiovascular mortality, MI 22%, cardiovascular mortality only 14%, non-fatal MI 22%, and total mortality reduction was again 14%. Next. So in HOPE study, it was done on almost 10,000 patients. Diabetes patients was 40%, hypertension almost 47%, peripheral arterial disease 43%, previous stroke 10% of the patients. In Europa trial, it was a bigger trial, 12,000 population, diabetes almost 12%, hypertension as 27%, peripheral arterial disease 7.1%, previous stroke 3.4%. Mean age in a HOPE trial, it was 66%, Europa trial, it was 60%. Female recruited in this HOPE trial was 27%. Background medical therapy in females, beta blockers 39%, antiplatelet 75%, lipid lowering agent 28%. In Europa trial, background medical therapy, beta blocker is 62%, antiplatelet 91%, or rather 91.9, almost 92%, and lipid lowering therapy 57.8, that is 58%. So number to treat is 50 patients. If we treat for 4 years, we can prevent one cardiovascular death. Next. So Europa trial was on less serious patients. So we needed increased number of patients to prevent one death. This is another trial. That is the LIFE trial. It was a double-blind, randomized, parallel group trial. Subset 55 to 80 years of patients, essentially hypertension with LVH on ECG, losartan 50 milligram OD versus atenolol 50 milligram OD. Dose increased to a maximum 100 milligram OD. Follow-up 4 years. Losartan group showed relative risk reduction in total mortality. There is a 20%, stroke 25%, new onset diabetes 25%. Losartan was better tolerated. Rate of MI remains the same in both the groups. Next. So in diabetic subset, double-blind randomized parallel group, diabetes with essential hypertension with LVH. Again, it was with losartan 50 to 100 milligram, atenolol 50 to 100 milligram. Losartan group showed reduction in mortality, 36%, MI 16 to 17%, and stroke by 21%. Next. So meta-analysis of all these trials, including RCTs, reported the effects of ACE inhibitors and ARB regime for diabetes mellitus patients on total mortality, CV death, major CV events with an observation period of at least 4 years. Not all patients and this are hypertensive in these studies. AC inhibitors, we have got number of trials. ARBs, again, we have got number of trials that is starting from SJ, Profess, Scope up to Detailed Stat 2004. In AC inhibitors, we had number of trials from JMIND to Stop Hypertension and Sano trial in 1994. And this HOPE trial again was published in 2000 and 2000. HOPE 3 was published in almost 2008 or 2009. Next. So ACEI reduced all-cause mortality, CV death, and major CV events in patients with type 2 diabetes, whereas ARB had no beneficial effect on these outcomes. Next. So this trial again showed RCT for hypertensive patients with type 2 diabetes, treatment with ACE inhibitors or ARB. Endpoints are all-cause mortality, CV death, major CV events, MI, stroke, with an observation period of 12 months. More than 500 total participants in each study. That is the ACEI almost 25,000, ARB is 22,000. ACI studies included HOPE trial, advanced trial, high-weight trial. High-weight trial was for hypertensive patients more than 80 years of age. Perindopril was used, and that showed significant benefit. ARB studies, that is Scope, Profess, Roadmap with this olmesartan, Orient renal trial with irbesartan, and this Trescent trial again with this telmisartan. Next. So, outcome of hypertensive patients with type 2 diabetes, all-cause mortality was significantly reduced. Then this with this AC inhibitors, CV death 17%, MI 23%, stroke 12%, heart failure, heart failure, 35%, CV event 17%, ARBs, all-cause mortality, no significant difference, CV death, almost no significant difference, same as MI, stroke, heart failure, and CV events. Next. So the conclusion is that ACE inhibitors showed significant CV protection for all-cause mortality, CV death, and in hypertensive patients with type 2 diabetes mellitus. ARB has no beneficial effects on the outcome except MI, but that is also controversial. We shall come to it. In view of differential benefits on mortality and morbidity, ACE inhibitors appear preferable to ARB for patients with hypertensive patients and type 2 diabetes. Next. So key message is that hypertension and obesity increase the risk of vascular complications in diabetic patients. In view of differential benefits on mortality and morbidity, it appears over ARVs for patients with hypertension and diabetes. The benefits of ACE inhibitors are consistent. ACE inhibitors could be the drug of choice for intervention in primary prevention of diabetic kidney disease. Next. So we have got two more trials. Number one is the guideline recommendation. Number two is the trial that is published almost 3 years back. That is with Paradise MI trial. There was almost 6,000 patients are included, and they are subdivided with the ACE inhibitors and this ARNI group, ARNI, and that showed that this primary outcome was almost the same. That is the MI, stroke, and CV death was same in both the groups. So, and number two is the guideline published by ESC this year in 2024 in patients with CCS, and ACE inhibitors has become a class 1 indication in CCS patients with type 2 diabetes, as it prevents cardiovascular complications, stroke, and CV death. So with this, we'd like to go for these discussions on this the subjects we have to discuss today. So first is we go to Dr. Partha Chaudhary. Well, Dr. Chaudhary, welcome. Good evening.
I can see the question on my screen. Just as you have
Yes.
just mentioned, the dose at which ACE inhibitor is having maximum anti-atherosclerotic properties about 10 mg on preventing plaque rupture. So prevent plaque rupture.
Obviously, I fully agree. So I asked this question to Dr. Kim Fox when he came to India. He was a principal investigator of, again, that is the beautiful trial and other trials. So he said also, I also asked the same question to Dr. Selim Yusuf, who is the main man for this HOPE trial. And that showed to get the maximum anti-atherosclerotic benefit, we should have almost 10 milligram of Remipril daily. Lower doses is antihypertensive, but it doesn't produce significant anti-atherosclerotic effect. Right. So we go to the next question. So if possible, one should try to increase the dose to 10 milligram daily. So higher doses in lower BP patients does not reduce the blood pressure that much. It is because in HOPE trial, when these patients, when hypertensive patients that are controlled and add on this Remipril, they produced only 4/2 millimeter systolic and diastolic blood pressure reduction in hypertensive patients. So ARB paradox, this is from the value trial. Unexpected relationship of ARB with MI may aptly described as ARB-MI paradox, and thus first raised as an issue in 2004. In value trial, for more than 15,000 patients are taken into account, more than 50 years of age, treated or untreated hypertension and high risk of cardiac events. A randomized double-blind parallel group comparison of this therapy based on valsartan and amlodipine. See primary composite endpoint, no significant difference. Cardiac mortality, morbidity, and all-cause mortality were noted between the treatment groups. Amlodipine group had a significant lower incidence of MI and higher rate of new onset diabetes than that of valsartan group. You can see the Kaplan-Meier curve. There is the primary endpoint. There is the primary composite endpoint is almost the same in both the groups. Next. So from the value trial that predicted the primary endpoints, it's almost the same. Myocardial infarction is again was higher in the group where that is the ARB was used, that is the valsartan. Fatal or non-fatal MI, you can see that is higher. Although not significant, it was higher than the group who are on amlodipine. And amlodipine also showed significant reduction in the incidence of stroke. Right. Next. So relative risk reduction of MI, AC versus ARBs. If you can see IDNT, charm alternate trial, value trial, and high pressure scope live trial on target trial. Although that reduced the incidence of MI, but that was not statistically significant. Whereas you see HOPE trial and Europa trial, there is huge benefit in reduction of AMI or following the AMI patients, following this AMI patients to use this drug to prevent subsequent atherosclerotic effect. Next. So AC inhibitors plus ARB, you see, that is the AC inhibitors produces vasodilation, anti-aggregation of platelets, anti-proliferative effect, stimulation TPS synthesis, cytoprotection, endothelial dysfunction correction, and plaque stabilization. On the other hand, if you see on the right hand side, that is the ARBs. They have got number of receptors 81, 82, 84, and again receptor 1/7. That is beneficial effect is mostly with these 81 and 817. So anti-proliferation effect is doubtful. Antioxidant effect is there. Neuroprotection, apoptosis effect is doubtful. So it produces vasodilation, anti-inflammatory effect, improved endothelial dysfunction, reduces hypertrophy, anti-proliferative effect. But its effects on this hypertrophy prevention is doubtful, remodeling is doubtful, plaque stabilization is doubtful, inflammation reduction is doubtful, increased expression of pi occurs with these ARBs. So endothelial dysfunction and proliferative effect, prothrombotic effect is also higher with ARB compared to these AC inhibitors. Next. You see what causes the plaque rupture. If you see this with these ARBs, there is higher serum level of this metalloproteinase 1, which produces plaque. That is the increase the intercellular inflammation and produces plaque rupture. If you see with these AC inhibitors, this bradykinin effect. Bradykinin has got two receptors, 1 and 2. The vascular receptor 1 that produces that increases the serum nitric oxide level, and that is helpful in this plaque stabilization. So if you consider plaque stabilization, AC inhibitors is obviously better than that of ARBs. Next. So meta-analysis of all these studies, AC inhibitors versus comparators, there is significant benefit. You can see in global death, CV death, stroke, and MI. But ARB with the comparators, again, stroke incidence is low, but MI incidence, CV death, and global death, that is the total CV death is not reduced. Or subsequently, you can see MI incidence is higher in ARB group. So in hypertensive patients who is likely to have myocardial infarction, we don't use these ARBs. We use rather ACE inhibitors. Next. And also post-MI follow-up or post-PCI. We use ACE inhibitors, then ARBs. So question to Dr. Nirav Kumar. ARB-MI paradox. Is this paradox a reality or a myth?
I think this is more or less controversial topic, whether it increases the incidence of MI. In on target trial, they compare the AC inhibitor and ARB. There was no increase in MI incidence, but definitely theoretically it's look like that AC inhibitor is better. And most probably there are some evidence also. That's why in guideline the first drug is AC inhibitor, and if it is intolerant with AC inhibitor, then ARB. What is your opinion, sir, Doctor?
Yes, I fully agree. I fully agree that in on target trial, they showed the benefit is same in both the groups. But if you consider all other trials, then this meta-analysis of all these trials, AC inhibitor scores over ARB. So as I said, in my patients who are prone to this development of this MI, I prefer AC inhibitor. Also in patients who are have MI, who are managed medically, I give AC inhibitors first. Then, if patient is intolerant, we go for these ARBs. Mostly we use two drugs, either telmisartan or valsartan. But if the patient has got a heart failure, you can use AC inhibitors. This is the AC inhibitors again. These are the two molecules, ramipril and perindopril. Either another is quinapril, we do not use. We don't have at present. But these two drugs are more beneficial than other drugs because apart from reducing the circulating S, it also reduces the plaque S, and also that is the tissue S, and that is beneficial. That's why we try to use these two drugs. Another question, in patients with chronic coronary syndrome with hypertension, what will be your choice as an antihypertensive drug, ACE inhibitors or ARBs? Dr. Nirav?
Sir, I missed the question, sir.
Yes, in patients with CCS, chronic coronary syndrome with hypertension, what will be your choice as an antihypertensive drug, ACE inhibitors or ARB?
Definitely AC inhibitor will be better, sir, in this condition.
So, as I said in the guideline, 2024, published almost 2 to 3 months back. It was published in June or July, something like that. And they had ACE inhibitors is a class 1 drug in chronic coronary syndrome, especially diabetic patients, because we have got significant proof it reduces vascular complications, MI, stroke, and cardiac death. So, along with these other drugs, it is included as a class 1 drug. We try to use it in patients in coronary syndrome, especially if the patient is hypertensive with diabetes. Right. Next. Based on on-target study, should telmisartan be considered bioequivalent or non-inferior to these AC inhibitors? Who will take up the question? Abhishek is there, na? Okay. So you can see there is the on-target and TRESCENT trial. Follow-up period 3.5 to 5.5 years. So on-target, that is the telmisartan was used, and that showed non-inferiority of telmisartan compared to ramipril for primary outcome, that is CV death, MI, stroke, hospitalization for heart failure. And if you consider the TRESCENT trial, again primary outcome, that is the CV death, MI, stroke, hospitalization, heart failure is almost the same in both the groups. So primary outcome, if you consider, that is the opposite of CV death, non-fatal MI, stroke, hospitalization for heart failure, same in both the group. Secondary outcomes, newly diagnosed CHF, that is the cardiac heart, that is the chronic heart failure, revascularization procedures, newly diagnosed DM, development of dementia, cognitive decline, nephropathy, and weakly diagnosed, and the newly diagnosed AF is almost the same. Other outcomes are all-cause mortality, non-CV death, angina, TIA, development of LVH, microvascular complications of DM, changes in T and in ankle arm BP ratio. Again, that showed almost the same in both the groups. Next. So, if you can see the on-target study, ARB achieved a lower BP, marginally better than AC inhibitors, but also showed non-significant trend of 47% increase in MI. ARB, telmisartan, was not inferior to AC inhibitors for reducing the risk of events overall and including CV death. And effects of angiotensin receptor blocker, telmisartan, on cardiovascular death is high. Risk populations intolerant to angiotensin inhibitor enzymes in a randomized control trial. Again, that showed that the AC inhibitors is the first line. If not, then we go for this ARBs. Next. Event rate with this in the TRESCENT trial, no significant reduction in primary composite outcome of cardiovascular death, myocardial infarction, stroke, or hospitalization for heart failure patients with ARB versus placebo. Next. So now we go to Abhishek. Abhishek, combination therapy is preferred over monotherapy in hypertension. How can we reach the maximum dose as suggested by key trials to obtain maximum CV benefits? In HOPE trial, 10 milligram daily, on target 80 milligram daily, tell me certain. We are practically using these as monotherapy doses. Are we practically use these drugs at monotherapy doses?
So, the question here asked here is specifically about hypertension. Most of the time, for ACE inhibitors, we have a predisposition in conditions where there are some added indications like apart from hypertension, the patient is having a coronary artery disease or a LV dysfunction or a diabetes. Means that drags us more towards the ACE inhibitors. But as such, if we talk about the potency, the ARBs are slightly more potent in antihypertensive effects as compared to the ACE inhibitors. But again, if we have an option, and actually this hypertension classification is not used anymore, but previously we used to say that if the patient is having a systolic blood pressure between 140 to 160, we can try it with a single antihypertensive. But if it's going more than 160, we'll have to use a combination. So in that conditions, if we are using a monotherapy and the patient can tolerate it, we'll go for the maximal dosage of the ACE inhibitors. If the patient is not getting control, then another drug can come. And again, in that condition also, we'll have to look at that we are treating only hypertension or some other things. Like if it's only hypertension, then apart from a ACE inhibitor, we can add a calcium channel blocker. Otherwise, if the patient is having a coronary artery disease, then if possible, we can add a beta blocker or drugs which can give us some benefit in that conditions also. So
Yes.
yes,
Yes.
monotherapy, yes,
Yes.
but most of the time when the patient comes to us, they're not actually borderline hypertensives. They are usually having a significant high BP. So combination therapy is required in most of the patients.
I agree. That is the ESC and SC. That is the American guideline. That is the ACC guideline. ACC says this is the in patients who are with between 130 to 140 with the comorbidities, single drug, and also in patients over the age of that is the 60 years who are frail, and they can use that is the single drug, and also in patients who are high blood pressure, the target blood pressure is not more than 20/10. We can use single drug. Otherwise, we should use two drugs. Now, again, which two drugs? We have got a very good, that is the trial, that is the accomplished trial. That was almost on more than 12,000 patients. That was with ramipril, that is not ramipril, it is perindopril, with there is diuretic, or that is the calcium channel blocker. And that showed there is the SC inhibitor, that is ramipril, perindopril versus this it is the calcium channel blocker. They significantly reduce the blood pressure, and also side by side they produce significant vascular protection. Relative risk reduction was in more than 20% so far as non-fatal MI, non-fatal stroke, and sudden cardiac death is concerned. So we go for two drugs regime in most of the cases. And if you say that is the target dose, yes, if you use 10-20 gram of ramipril, also use in some cases telmisartan 80 milligram daily, but they are not as potent as that of these calcium channel blockers. There is the non-dihydroperidine, there is the calcium, there is the amlodipine, cilindipine, all these groups of drugs. So we try for vascular protection 10 milligram of ramipril, but single drug is always, it's sometimes not adequate enough. We use calcium channel blocker in combination to get the maximum benefit. Calcium channel blocker is the main drug to reduce the central aortic pressure and subsequently the reduction of stroke. We all agree. So we try to get the 10 milligram daily ramipril to get the maximum atherosclerotic effect. But with hypertension, it is with these calcium channel blockers. We follow the NICE guidelines. That is the A, B, C, D. More than 55 years, C, D. That is the calcium channel blockers or diuretics. Less than 55 years, that is the AC inhibitors or ARBs. And now, the recent guidelines by these ESC, they say we can use this beta blocker at any stage of hypertension management, right? If the young patients who are, especially in females, they are hypertensive, the sympathetic overdrive is there, we use these beta blockers, right? So that depends on the comorbidities, which type of patient it is. But one thing is sure, we try to achieve 10 milligram of verapamil in our day-to-day practice to get maximum anti-atherosclerotic effect. Next. Again, Dr. Partha Chaudhary, what is your perspective on the clinical evidence of comparing ACE inhibitors and ARBs in the management of hypertensive patients with diabetes? Do you believe one class is superior to other in improving long-term outcomes? Dr. Partha Chaudhary?
I can hear you.
Yes.
Sir, just you have discussed, we have a robust evidence and guidelines, trials and meta-analysis, which suggest ACE inhibitors definitely have benefits, especially in those hypertensive patients who are having multiple risk factors. So they should be given ACE inhibitors for having the maximum benefit and for having long-term outcome. They should be given.
Do you believe one class is superior to other in improving long-term outcomes?
ACE inhibitors should be preferred as compared to ARBs for improving long-term outcome.
So, Dr. Chaudhary, if the patient has got renal dysfunction or to prevent renal dysfunction, and this ARB has got the more trials and more beneficial effects compared to these ACE inhibitors. What is your view? For
Sir,
renal prevention, we have got number of trials.
Sir, for renal
with ARBs.
I agree, but overall, sir, these diabetic patients are overall ACE inhibitors improves cardiovascular mortality, MI, heart failures. These sort of risk factors are more likely. It is more likely to be prevented by use of ACE.
But we prefer when there is the nephroprotection is concerned. So we try to go for ARBs in those cases, right?
Yes, sir.
Not all ARBs, especially telmisartan. It has got a huge evidence that it reduces the nephroprotection. Also, it prevents deterioration of renal function.
Yes.
Right?
Yes. Sir.
Yes. Next. But if you have a cardiac protection, obviously, ACE inhibitor is superior. And also, post-MI follow-up, ACE inhibitor is superior. Post-PCI follow-up, we routinely use these ACE inhibitors, not ARBs. Dr. Nirav, how do you weigh the renal protective benefits of, again, ACE inhibitors versus ARBs in diabetic patients, especially in those with diabetic nephropathy?
I think you have already answered this question, sir. Definitely in
Yes.
renal trial, there was definite benefit in favor of ARB, and in which losartan was used. Even in recent the Paradigm HF trial, the enalapril versus valsartan with the neprilysin inhibitor, there was benefit with the ARB arm. So definitely ARB is better than the SLB.
But one thing is that in type 1 diabetes, in younger patients with nephropathy, diabetic nephropathy, ACE inhibitors is superior to ARB. But we get mostly type 2 diabetes with nephropathy, where we use, even the diabetologist use this ARB, mostly telmisartan. Right, next. Dr. Abhishek, in your experience, do ACE inhibitors or ARB offer superior blood pressure control in patients with both hypertension and diabetes? Does one class provide better outcomes in terms of reducing cardiovascular events?
So answer for the second part of the question is much more clear, and it's a bit dicey in the first part. Actually, regarding the potency of the antihypertensive, ARBs are more potent as compared to ACE inhibitors usually in reducing blood pressure. So if we talk only about superior blood pressure control, ARB is the preferred thing. Especially we are talking in diabetics also. So yes, there also ARB, especially telmisartan, gives us a very good blood pressure control and also renal protection in these hypertensive diabetic patients, the renal protection is better with ARBs. But if we talk about cardiovascular event reduction, definitely ACE inhibitors have an edge because most of the trials have shown them to fare better because they, apart from controlling the blood pressure, they also have an anti-inflammatory effect and the plaque stabilization effect. Just like the statins, they also have an anti-inflammatory and a plaque stabilization effects. So yes, if we talk about cardiovascular events, they are reduced by usage of ACE inhibitors as compared to the ARBs.
So, yeah, I fully agree with Dr. Abhishek. So, if the patient is hypertension and diabetic, so for these patients, telmisartan is superior so far as the nephroprotection is concerned. And telmisartan will also prefer in those patients there is no comorbidities, diabetic in younger patients, especially because of the fact that telmisartan has got a very long half-life. It has got the highest smoothness index, trough and peak ratio is very small. So it's a sustained effect for 24 hours. Number two. Number three, it structurally is almost similar to that of pioglitazone. And let's say that it reduces by that the insulin resistance. Number four, it has got this anti-lipid effects. Although theoretically, I don't know, but the lipid effects, that is, it reduces marginally LDL level. So in diabetic patients who have got no other comorbidities, ACE inhibitor is it can be used because, and number four is that ACE inhibitor, that is the ARBs, are well better tolerated than ACE inhibitors. Almost 20% of our patients have cough or some amount of COPD, bronchitis, all those things. So in those patients, we are very hesitant to use these ACE inhibitors. Whereas ARB can be used. ARBs are user friendly. But if you consider the nephroprotection, again ARB is superior in type 2 diabetic patients with hypertension. But if in cardiovascular protection, cardiac protection, that is it is by these ACE inhibitors, either this ramipril or that is the perindopril, because as I said, it reduces the tissue ACE, and that is important in our practice to reduce the cardiac events. Right. Next. Dr. Chaudhary, in your experience, do ACE inhibitors or ARB offer superior blood pressure control in those patients with hypertension and diabetes? Does one class provide better outcome in terms of reducing cardiovascular events? We have discussed still. Dr. Partha Chaudhary? So if he is not here, or his link is causing difficulty, so let me answer. Anybody like Dr. Nirav Kumar or Dr. Abhishek, you would like to answer?
I think we discuss the hypertension
Yes.
control with the ARB is better, more potent than the ACE inhibitor.
Right.
The definitely majority of the trial definitely there is evidence in favor of ACE inhibitor for cardiovascular protection.
Yes, sir. Actually, the last
Right.
question was nearly similar to this
Yes.
question, which because again it's hypertension with diabetes, and the second part is regarding the cardiovascular event protection. So it's the same question again. So we have already discussed this.
Right. We have discussed it, right? Yes. 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 Next. Next. So, Dr. Nirav Kumar, is merely reducing target or goal BP important or selecting the right antihypertensive agent too should be considered, especially in patients with comorbidities like coronary artery disease?
I think right antihypertensive agent is more important than the target achieved. Already in Indian scenario, most of the patient with IMI or comorbidity, there is usually blood pressure is not on higher side. They barely tolerate higher dose of AC inhibitor or ARB. So majority of time, the target should be the right antihypertensive agent.
So blood pressure can be reduced by any drugs. They have first line, they have got 6 drugs. That is the ARBs, ACE inhibitors, then these calcium channel blockers, diuretics, and these are the four groups of drugs. Also nowadays beta blockers. But if target is can be achieved by any of these drugs, but if we need vascular protection, obviously there is the ACE inhibitors or ARBs are to be used. As I have said, for this cardiovascular cardiac protection, there is the ACE inhibitors, nephroprotection in type 2 diabetes with hypertension, that is the ARBs. Right. Any other question? Oh,
I think this is the final question which
so, yes. Dr. Abhishek, in patients with chronic coronary syndrome with hypertension, what will be the choice of antihypertensive? We have discussed.
without any doubt ACE inhibitors because of its anti-inflammatory effect,
Obviously.
reduction in cardiovascular
Yes.
mortality, reduction in chances of MI. So ARBs are definitely to be preferred.
Right. So, one more question. There is the two things, as I have said. In post-MI situation with LV dysfunction, nowadays I've seen some of my colleagues, they were using this ARNI. But I always try to say them, see, we don't have the trial that post-MI within 3 months. That is helpful. So, and that came with the Paradise MI trial, and that showed this. There is the primary endpoint reduction. Both are same. So, what's your view? Have you used?
So actually not, because in acute MI we don't have data in these patients. It's a drug which is to be used in stable
Yes.
coronary artery disease with significant LV dysfunction. And now we say reduced ejection fraction or mildly reduced ejection fraction has been added of late for these RDs, but not in a patient of MI immediately, means in immediate recovery period. So we don't have the data.
There is increased
So,
chance of renal failure also. Acute renal failure will increase because of
okay.
the hypotensive effect of the ARNI.
Exactly, because they are acting as a very potent antihypertensive also. So many a times these patients are already having a borderline LV function. They are in failure. We are also using diuretic, and along with that, if we are using a ARNI, which is a potent antihypertensive, the patient may have renal perfusion issues. Renal dysfunction can get worsened.
So suppose take a scenario that is the patient has come and we have done primary angioplasty, and we get most of the time that is the ejection fraction is 35 to 40. What agent will you use? We have got ARB, we have got ACE inhibitors, we have got ARNI.
So actually, there are different answers apart from beta blocker. That will be the first drug to be added from this side, and after that, ACE inhibitor as such. But if we are seeing that there is a significant permanent damage to the myocardium and the patient is very unlikely to recover his LV functions in the recent time, many times doctors start with the ARB because it becomes easier from to switch from ARB to ARNI. And if you start with the ACE inhibitor, then you'll have to give a washout period, and after that you'll start with. So I've seen people doing this, that they start directly in these patients of MI with ARB, and after say 3 months, if they don't find the improvement in a LV function, they switch over to ARNI.
Actually, you're right. So after an infarct, remodeling takes place almost 3 months time. So during that period, it is better not to use ARNI. We use the ACE inhibitors, or if we use at all, that is the ARB, it should be valsartan in LV dysfunction, because the telmisartan we don't have much data. Only data
Yes.
we have is the value trial. There is valsartan, right? So we can use it after 3 months and then wait. We have seen substantial number of patients of primary angioplasty we have done. In 3 months' time, their ejection fraction comes up to 40, 45, 45. So they don't require after that this group of drugs ARNI. So and also after MI, if there is a remodeling occurs, as I have said, for the 3 months, after 3 months, there is the ejection fraction is more than 50%. We don't use this. We can stop these ACE inhibitors or ARB, and we should continue with this, especially if not the patient is not diabetic.
Yeah.
Yes. If the patient is diabetic, obviously we shall continue ARB or ACE inhibitors or ARNI in those group of patients. And the last question, as I said, in CCS patients, in diabetics, it is a class 1 drug. Do you use it, especially in diabetics?
So
That is
yes,
published almost, as I said, in July.
yes, renal protection is definitely there. So we should use it in most of our patients if there is no other contraindication or
No,
something.
for CCS, for CCS,
For the CC,
CCS, chronic coronary
okay,
syndrome.
okay. Yes, for the anti-inflammatory effects, we can use it because that will lead to plaque stabilization and better insulin sensitivity in these patients.
Yes, so it is a class 1 drug apart from these beta blockers and other, especially in diabetics. So to sum up from today's discussion, it is very clear that ACE inhibitor, especially ramipril and perindopril, has got a place in the treatment of cardiovascular diseases like CCS in diabetics or in heart failure or blood pressure reduction in patients who have comorbidities. So we should not jump to other drugs like this ARNI and others from the very beginning, because ARNI is a very rather a strong antihypertensive drug, and also it should not be used in patients who has got renal dysfunction, who are hypotensive, and those who are these dehydrated patients, because that can produce the catastrophe. So ACE inhibitors has got definitely a role in our cardiovascular management. So what's your view? Last comment, Dr. Abhishek and Dr. Nirav.
I think, sir, one thing I want to add, sir, because after the COVID, recently we are noticing in Bihar, in Patna, there is increased chances of cough and incessant cough, not controlled by any medication if someone is taking ACE inhibitor. And this is very common. Up to 25 to 30% patient develop severe type of coughing. So what is the
Yes, yes, I fully
exactly? I
agree.
don't know.
I
So
fully
that's
agree.
why we are fearful in adding or starting the AC inhibitor,
So
particularly
yes, yes, I fully agree. As I have also said, that if almost 20% of our patients, they have got either overt bronchitis or COPD or asthma. And some are subclinical, and there becomes obvious with the use of AC inhibitors. You must be very cautious because incidence of cough and COPD is very high in our population. So in those cases, we should be very cautious to use these AC inhibitors. Rather, it is safe to use ARBs in those cases. Right? We only agree.
Actually, in view
So
of this cough only, most of the time, if the patient has come only with hypertension and there is no other compelling indications, most of the clinicians play it safe and directly start with the ARB because the incidence of cough is lesser. Dry cough is significantly lesser in these ARB patients as compared to the ACE inhibitor patients. So, if you don't have a LV dysfunction, if you don't have a diabetes, is a young hypertensive who has come to your clinic, not very keen in regular
right.
follow, in those patients, it becomes very difficult to start with ACE inhibitors as a first drug because if the patient develops cough, they get irritated that, look, there's another
Yes.
problem which has started apart from this hypertension. So, yes, mostly we get guarded on
Yes,
this.
I fully. So these ARB are very user-friendly drug. Chances of complications are less. Patient's tolerance is good. So in those patients, as I have said, in younger patients, we use AC inhibitors, right? ARBs rather than these AC inhibitors. But in patients who have got comorbidities, obviously we shall use it. So we are almost at the end of our discussion. We had a very good discussion on this ARBs. And over to this Dr. Ronak or
Yes, sir. So thank you so much, Dr. Ganguly, Dr. Abhishek, Dr. Neeraj Kumar, and Dr. Partho again for an insightful discussion. We were really hoping to see what your clinical views are regarding the use of ACE or ARB, especially in the hypertensive diabetic population. So thank you so much for highlighting your clinical insights for the same, and I'm sure that all the audience has also gained something more out of this discussion. So thank you so much, everyone. And
Thank you.
Ronak, any question from the audience?
no, sir, no
Any question
questions,
from the chat
no
box?
questions from the audience.
Okay.
Yes. And I
So we
think the
can.
discussion was well enough to summarize everything, and you have also asked a few more questions, which kind of picked and choose all the other aspects of this topic. So thank you so much, Dr. Ganguly. It was really a pleasure. And yeah, with this, I think we can end the session, sir.
Good time to summarize to 2024 also.
Right.
Okay.
Thank you.
Hopefully, the good thing happen in 2025.
Right, right.
Good night. Good
Hope
night.
for the best for the next year, 2025, to all of you.
Yeah, all
Stay
was
safe.
Happy New
Right.
Year.
Happy New
Thank
Year,
you, sir.
everyone.
Thank you very
Happy New
much.
Year, sir.
Okay.
Happy New Year.
Happy New Year, boss. Thank you so much.
Thank,
Thank
thank
you.
you so much, sir, for taking your time and joining the session, sir. Have a great day, sir.
Okay. Thank you.
Thank you,
Thank
sir.
you. You can end it.
Yeah.
Yeah,
Please.
yeah. Nirav, we can stop the live, okay? And we can close this.
Recording stopped.
Thank you.
चलो बढ़िया